Hello, my name's Andrew Bayliss. I'm a consultant anaesthetist with NHS Grampian and I work for the Scottish Ambulance Service at the MRS North. We're going to talk about pre-hospital analgesia, the drugs you might encounter, the methods of administration, and some of the more significant side effects and risks associated with using those drugs. Some of them you'll be familiar with, some of them you'll be comfortable with, drugs like paracetamol and morphine. There are other drugs that you may not have come across before, but may have heard about, drugs like ketamine, fentanyl. First, we'll touch on the WHO Analgesic Ladder, and we'll also talk about the definition of pain, which is an unpleasant sensation associated with illness or injury. Pain is subjective. The patient will tell you what their pain is. The WHO Analgesic Ladder is mainly for chronic pain, cancer pain, but is applicable to acute pain, such as that encountered in trauma, with the caveat that you may need to step further up the ladder or start at the top. The WHO Analgesic Ladder is a stepwise approach to introducing analgesia stronger and stronger as you need it. So first of all, let's talk about the different routes in which we can administer medication pre-hospitally. We've got the obvious ones of oral and intravenous. We've got intramuscular, we've got intraosseous. There's also inhalation, intranasal, buccal, topical. I'm going to talk about some of the analgesics now that you may be familiar with using. Paracetamol and morphine to start with. Paracetamol is a really useful drug. It's a simple analgesic, but it works well in conjunction with the opioids and potentiates their effect. That allows you to get a bigger bang for your buck with the opiate that you're administering. Paracetamol can be given orally or intravenously. The intravenous preparation has almost revolutionized the use of paracetamol as an analgesic. Certainly very useful for patients who aren't conscious enough to take the oral preparations. It's a 15 milligram per kilogram dose for intravenous administration, and if you're over 50 kilos you can have a full gram. Moving on to morphine. Morphine is another drug you'll be familiar with. We use it quite a lot. It's cheap and cheerful. It's a CD, so obviously you keep it in a locked box and need access to it. We make it up in 10 milligrams in 10 mils, so it's a milligram per mil. Morphine is given intravenously and we titrate to effect. You can always give more, but you can't take it back, so it's best titrating up to adequate analgesia. You may have to give an antiemetic with it because it can cause nausea as a side effect and vomiting. It can cause sedation. It can also impair respiratory function, so just be careful with it. Entonox is another useful analgesic. It's an inhalational analgesic, so it's in gaseous form, carried in a cylinder. Patients have to be conscious to be able to use the regulator to administer the drug. It's fairly quick onset, but it does take a minute or two to reach peak effect, so be aware that they need to be breathing it for a minute or two before they're going to reach that level of analgesia where you can maybe manipulate their fractured limb into a splint. It's a useful drug and is often overlooked. One interesting issue with Entonox is that if it's stored in a cold environment, you can get separation of the two gases, the oxygen from the nitrous oxide. And this can lead to two layers of gas within this cylinder. The upper layer being the oxygen, which will be breathed off first with no analgesic effects. And then the second layer will be the nitrous oxide, which will be a hypoxic mixture, which could cause problems for the patient if they're breathing this alone. This can be easily overcome by inverting the cylinder a couple of times just to remix the gas before use. Just be aware of this if your cylinder's been stored in a cold vehicle overnight. Penthrox is another gaseous analgesic that we use. SORT certainly carry it. Some pre-hospital responders, basics responders, are now carrying it. It is an anesthetic inhalational agent, but at the doses used pre-hospitally, predominantly it's the analgesic effect that we see. Be prepared for a bit of sedation when you use it. It is a potent analgesic, and for that reason it is used by people who are appropriately trained to use it. There is a cautionary or warning card that comes with it, some questions that you need to ask the patient to make sure that it's appropriate for them to use. It's for the adult age group only. Fentanyl is a very potent opioid that you may come across. Its routes of administration are intranasal, buccal as mentioned, intravenous and transdermal. It's available in patches, which we won't use in the pre-hospital environment, but you may come across patients who have fentanyl patches already on, as it's used for chronic pain. Fentanyl is considerably more potent than morphine, and so the doses used are measured in micrograms rather than milligrams. The advantage of using fentanyl in the mountain rescue environment are that you don't need to expose any part of the patient, but can ask them to suck on a lozenge, which uses the buccal route for administration and can be as quick onset as intravenous, providing potent analgesia to the patient and allowing them to be mobilized. Another advantage of fentanyl is it can be administered by the intranasal route, and for this reason it has a growing use in the pediatric population. Another drug that's useful for the pediatric population because of the intranasal administration option is diamorphine. The advantage of the intranasal route is its rapid onset and the no requirement for intravenous access, which in the pediatric population is useful. Diamorphine itself is more potent than morphine, has more euphoria. Ketamine is an interesting drug. You may come across it during your work. You won't be using it yourselves, but there may be specialist teams and basics responders, doctors who carry it and use it. It has different effects depending on the dose given. So at low dose, it's a potent analgesic. Mid doses, it's a sedative analgesic. And at higher doses, it becomes an anesthetic drug. Using ketamine, you need to be able to cope with the side effects, so you need to be trained to use it. It's very easy to move up from a sedation or analgesic dose towards an anesthetic dose, and you really need to be able to cope with the side effects. Ketamine is an interesting drug. It induces a dissociative state, so a patient may still feel pain, but they are not as aware of it or bothered by it. However, their interaction with reality may be adjusted and they may suffer hallucinations. Ketamine is a useful drug for providing sedative analgesia for undertaking painful procedures. It is also used in pre-hospital emergency anesthesia. Buprenorphine is another interesting drug that you may come across. There's a resurgence of use in the chronic pain community. It is a drug that has both agonist and antagonist properties. If a patient is taking buprenorphine for chronic pain, then you'll struggle to achieve adequate analgesia with the standard doses of morphine that you would normally be using. You're going to need to use more, and actually you're going to need to consider other drugs which are going to have a better effect by not having to rely on the opioid receptors that are occupied with the buprenorphine. Of course, it's important to remember the basics through all of this. Clear communication in a friendly manner, reassurance of the patient, splintage of fractured limbs, dressings, especially of burns and open wounds, avoiding unnecessary movement. Remember, you're part of a team and support is there if you need it. In summary, analgesia supplements good clinical care. There is no single fit recipe. Patient and situational factors will govern your choices. risks need to be minimized and managed. Thank you.